Okay, so for everyone that missed it, we're gonna go over this outline here. This is gonna be a little table that's gonna help categorize each type of chronic neuro condition. We're on Parkinson's. This is caused by deficiency in dopamine, which is your do it dopamine, lack of dopamine, you're unable to do it. So it leads to shaking. Think about if you guys go to the gym, they tell you to work out until you hit failure. So you get to that point where you start shaking because your muscles can't handle the weight. Kind of the similar idea where your muscles don't have enough of this, or not really muscles, but like your CNS doesn't have enough dopamine, so it can't properly function with the muscular wise. So that's where you have shaking, resting tremors. So similar to going to the gym and being unable to bear the weight, your body just kind of starts shaking. And this is going to affect your lifespan, make it shorter. The word Lewy body comes up a few times in terms of different diagnostics for it. Otherwise, it's primarily based on signs and symptoms. I believe there's no real way to measure the amount of dopamine in the body. So it is based a lot of the signs and symptoms that we'll talk about here. Here is what's called like the cardinal triad. So these are the three main signs that you'll see with Parkinson's. So you see the resting tremors, like we talk about, rigidity, so like muscle rigidity, and bradykinesia, meaning that the person's going to have a slower functioning of their muscles. They're going to be moving a lot slower. Their muscles are going to be more rigid. They're going to be having tremors. And something that might not be like something that comes to your mind immediately with Parkinson's, but this can also cause dementia. So that's something that can it can also affect your mental status and everything like that. And then here I have some other manifestations that you might associate with Parkinson's. So some of the ones that I see come up often is the shuffling gait, the pill rolling motion. I think those two I see a lot for manifestations of your Parkinson's other than the cardinal triad. And then here are some other ones. Mask-like face, so the blunted affect, ataxia, so lack of balance, which you can imagine is going to be happening with someone that's tremoring and has rigid muscles and slow movement. Drooling, so same thing, muscle weakness. They're not able to properly move their muscles, so they start drooling, unable to swallow properly. Although compared to some of the other ones, um, it's not, it's like some of the other conditions are more focused on like dysphagia. This one, not as much, but you can have some drooling. And then urinary frequency, so their bladder might be also impacted and they'll need to pee more frequently. Okay, so going back down some more. In terms of the management, here are the three medications that Mr. Robbins goes over. I think he's the one that does it. I think he does, yeah. So cinnamon, not cinnamon, but cinnamon. This one in particular, the signs and symptoms you can focus on. I would say focus mostly on the hypotension. That could be a potential sign and symptom to think about. You also want to watch out for toxicity. So this word is something that you guys went over for in psych. So let's see. There's something else like I know he mentioned. So when it came to the Cinemet, and let me specify this one is the carbidopa plus, I spell that carbidopa. Carbidopa plus levodopa. He talks about how it functions, but I don't think you really need to know like the deep pharmacological thing about it. Just kind of need to know that the Cinemet, these two together allow the dopamine to make it to the brain and help to prevent or help to manage some of the symptoms that you have due to the lack of dopamine. And just focus a lot on your hypotension, dyskinesia, nausea, vomiting. Um, but especially your hypotension, because orthostatic hypotension can happen, and then that's like a safety issue to think about. And then again, your tardive dyskinesia, we recall leads to involuntary twitching, eye spasms, tongue protrusions. So I would say think about that as well. Oopsies. So maybe we can add some of the signs and symptoms there. Protrusion. And something else he said was to take into account the timing. So the person might want to be taking it at the same time or take it with food or take it without food. The medication can cause nausea vomiting, like we mentioned. So sometimes taking it with the food is something they might prefer. Although the medication becomes slightly less effective because it works best on an empty stomach. But if they're not able to tolerate on an empty stomach, then having a little bit of food can help. Next one we have is the Maripex and the Requip. This one, the main key thing about this is it's pretty similar to the other one. It's not as effective, but also less likely to cause the tardive dyskinesia. And same kind of thing applies. The hypotension is your main thing. You can give with food because it can also cause nausea, vomiting. And then lastly is the cogentin, which is the benztropine, and this is the anticholinergic. Because again, you don't have to know the deep patho behind it, but the idea is that it's going to help to suppress the acetylcholine because it's anticholinergic, and that helps the dopamine to work a little bit better. The dopamine that they do have. It's also going to help with any, if you recall from psych, helps with the tremors, helps to prevent some of the tardive dyskinesia stuff. So, so some of the things you're going to be kind of assessing is kind of like the change in resting tremors. Let's see, treats it. So, yeah. So it's just kind of you're using it for treatment, so assess how that's making a change. And then as always, when you think about an anticholinergic, you want to think about the side effects of anticholinergic. So it's the can't see, can't shit, can't spit, all that stuff. See if I can just write that down so it's included in here. So when it comes to the people that have taken some of this medications, they can complain of dry mouth a lot. So, having that like bottle of water around might be something you want to do so they can keep their mouth not feeling like it's super dry. See if I can include that somewhere. Oopsies. Paste without formatting. So side effect of anticholinergics, dry mouth, constipation, urinary retention, blurred vision. They can't see, can't pee, can't shit, can't spit. And you're gonna want to take this with food. Take it during night to avoid drowsiness. And then moving on to the different types of management. I think this is what you want to focus mostly on. So I think meds, some of the signs and symptoms, and then the management. So with the management, this is a person that's having mobility issues, They're unable to move around, so they might not be moving around much. But one of your goals is to have them do some exercise, because it can help to maintain their strength and mobility. So keeping them on some sort of exercise regimen. We know from earlier classes or even just from like patients come in from like sniffs and stuff when they're not moving, that has a huge impact on a lot of body system, lack of movement, increased risk of DVT, skin breakdown, constipation, all of these the different things that lack of movement can cause atelectasis. So that's kind of your main thing. So here, exercise maintains strength, mobility, increase dopamine from the movement, um, and maybe it can also help with decreasing the fall risk. The gait is possible to improve. I'll also include here PTOT can also be effective assistive devices like a walker. And then your average question that you'll see on Kaplan where it's like, which one would you be uh which one of these actions would be like something further teaching? It's like, oh, I just put in a new throw rug. That's like the thing, like the some of the standard questions you might get. Here I do have a mention of the diet, but again, I don't recall this stuff being too emphasized here in terms of like diet teaching, but I do have it around anyways, just in case you decided to change the test up or if my memory's wrong, because I don't recall that well. But some of the things mentioned are high antioxidants, high fiber, moderate salt to help with the hypotension. So that might be one to keep in mind. Gets a little off the usual. So some of the other ones you can be like, yeah, fiber is probably good for most things. Making sure they get a lot of water, again, help with hypotension. And then the high fiber water also helps with the constipation, like we mentioned, where you're not moving around. The antioxidants is because it's believed that they help with protecting some of the cells that release dopamine. But again, don't need to know that deep. You probably won't get too much asked on this, but that's kind of the idea would be some things that help with the hypotension, high fiber because slower bowels can occur from lack of mobility. And then some of the things here would be the deep brain stimulation is something that can be done. What this does is it treats some of the tremors, rigidity, stiffness, walking issues. And this is um, done for those who are not being helped by the meds. I guess I should word that better. Done for those who are not seeing progress with medications. So if their medications aren't working, then we could try this, but you always do least invasive first. So the meds and the diet exercise changes would come first. And then lastly, it's just kind of assessing for swallowing and chewing to prevent aspiration. So even though this one's not like it's not like the utmost thing to watch out for compared to like the myasthenia gravis, we talked about how they could have drooling and maybe a little bit of difficulty swallowing. So it's still something that can happen. So you're gonna make sure to uh, assess for aspiration. This person's probably gonna be like aspiration risk, making sure that they don't aspirate and they're able to swallow properly. Okay, any questions on Parkinson's? Kind of went over it pretty quickly, but I do plan to get through these pretty quickly. And then again, just focus mostly on the management more than anything else. All right, cool beans. Multiple sclerosis. So this one is, and I have it kind of marked in all cap bolded. It's autoimmune. So we've talked about a few autoimmune conditions in the before and how, like with RA, we talked about the SLE, the lupus, the systemic lupus. and how some of your autoimmune conditions have similar symptoms. And this is I'm denoting these because they do come with the same some of the same things you've seen with those conditions as well, such as the fatigue that we'll talk about later down. But I kind of just marked it here so you can differentiate them from the get-go. So, but multiple sclerosis, autoimmune or thought to be autoimmune, leads to demyelation of your neurons and your like myelin sheath. Again, the lifespan, compared to Parkinson's, this one, the lifespan is gonna be not majorly affected, but your quality of life is affected instead. Another thing that might help you to note that is we see the ones that are autoimmune end up having only quality of life decrease, while the other ones are gonna have decreased life. So again, having the chart here hopefully helps differentiate them and kind of find some patterns to help you remember it for the test and then forget about it because you don't need it. No, I'm just kidding. But um, I don't think again, like I think the focus is mostly on your interventions and stuff, what to watch out for. So some of the diagnostics is they can do an MRI in order to diagnose it. So for when it comes to the little plaque areas along nerve routes and things like that. So something that maybe could come up is the MRI precaution. So knowing some of the things that the patient should not be allowed to go take in for the MRI. So no metal, anything. Specifically, I see mentions of like no wallet, some other things, maybe like assessing for anxiety, claustrophobia, because you're in a small little room. Something else that can be done is a lumbar puncture. We're able to see if they have this immunoglobulin in the cerebral spinal fluid. So that's something that might be specific for this one compared to the other ones, or is specific to this one. Okay. Um, Neuro exam and then signs and symptoms. So these are kind of similar. Basically, your assessment. The rest is your assessment. So when it says neuro exam, it's referring to strength, coordination, balance, numbness, pain, as well as some of your other signs and symptoms. And that we will go over here on the rest of the chart. So for manifestations, again, we set this as an autoimmune condition, so you'll see fatigue comes up because just like in RA, just like in lupus, fatigue is something that comes up pretty commonly with the autoimmune conditions. So that's something to think about. Your MS also comes with pain. So pain, and specifically maybe the trigeminal neuralgia. So that's the facial pain. So that's the cranial nerve 5. So we can see here this nerve, um, the trigeminal neuralgia would have pain amongst like along your face area. So that's what that means. It means like the facial pain. So this is facial pain. Okay, so that's like a big thing with here. And pain seems to be also like a common complaint with this condition compared to so we can by the end of it we'll kind of do like a quick review and see kind of like what are some standout things. So for this one I would say pain is like a standout thing. People will probably be coming in because they have this nerve face pain like early on in the condition, and that's when they'll do things to rule out. I know I actually had a patient in my first semester that he didn't have MS, but they thought he did. But he ended up having a different type of condition. Let's see if I think it was called MOGAD. That's what it was, MOGAD. So let's see. So another type of autoimmune condition that also affects the myelin protein. So it had a lot of really similar signs and symptoms. He was like a 23-year-old. He was coming in for optic neuritis, so eye pain. So whenever I think and again, like some of these signs and symptoms are actually similar from the MOGAD and the MS. So whenever I see this MS, I always think about that one patient. So I think about the nerve facial pain, and I also think about the vision changes a lot when I think about this patient because that's what he came in for. So when we saw him or when I saw him, he was having this optic neuropathy, so this pain in one of his eyes. And one of the things is that he was having this eye pain for a while now, to the point where he was having like eye pain in his left eye, but he actually came in because of sharp pain in his right eye. I remember there being something weird with the charting, like the nurse was talking about um that the patient was having pain in the left, but then when I actually talked to him, he was actually having pain in the right, and he had come in previously for pain in the left, and it impacted his vision. So some stuff that like wasn't charted or maybe assessed too well on that side, but that's what I always think about. So I always think with that person, I think about the nerve pain and the visual changes. But alongside all of that, it can also come with muscle weakness and spasticity. Again, this is something that's affecting the central nervous system. It's affecting your neurons. So you can kind of imagine that. And because the neuro exam is one of the diagnostics, you can start to think about how these things here are going to be like your major things affected. So alongside this, it also might come with elimination issues, hyperactive bladder, constipation, and we mentioned the poor balance as well. So kind of similar here, we see that there's going to be hyperactive bladder on both of these and like potential constipation. Okay, so then moving down, your management for this is a autoimmune condition. So this is something that you're going to want to think about your DMARDs and you're going to think about immunosuppressive stuff. So some of the medications here that get mentioned are I just kind of think of these like ABC. I don't even remember the rest of the word. I just like as long as I like can recognize it in a question, that's all I cared about. So I just thought of ABC and I just if I see these in a question, I know what they're referring to because I just know I recognize the word, but I don't memorize the word because it's too much to memorize at this point. You guys have so much content to memorize that uh some of those things are not going to be like straight from your brain. They're going to be like, if I see the question, I'll recognize it kind of stuff. So the idea behind all three of these, though, or at least mainly the first two, is that these are what they call interferons. So they're kind of like what's in the name. It helps to reduce the immune response. So they interfere with some of that. So both of these are there to affect the immune response. Meanwhile, this one, the zone, this is actually an amino acid that's found in the myelin sheath. So this helps to reduce damage to the myelin sheath. But again, I don't think you need to know that deeply. If like at most, maybe you might see this one called by its actual name. So interferon beta 1A. But again, don't worry about all like it's mostly about big picture things. Sorry, 1B. It's mostly about the big picture ideas more than it is about the small details on stuff that shouldn't matter at this point. Especially Mr. I think Mr. Robbins tends to be more practical in terms of his test, where it's more about your nursing interventions and like what do you do rather than like patho that as a nurse you don't actually use too much. I mean, to some degree, you want to know it because it helps. It might help you, understand why the medications are the way they are, why things are done the way they are, so you can do patient teaching. But nothing too insane like knowing the how interferon like directly works. Just kind of understand that this is something that helps with the immune response. So I'll kind of then. Meanwhile, the Copex zone, this is going to um block damage in the myelin sheath, and then the quote unquote patho behind it is that this is an amino acid and in the myelin sheath. But again, too much detail. Don't drown in it. Don't drown in the detail. Okay. Um, so in general, think about general for the above three is that they have the sign and symptoms. Uh, they can give you flu-like symptoms because of they are immunosuppressants. In general, they're going to be immunosuppressive. So I'm going to have here these suppress or alter the immune system. So in some way or form, these are going to do so. So that's a potential thing that you might have. You might have flu-like symptoms because of that. So that can include low grade, maybe like a fever, headache, body aches, stuff like that. And also keep in mind that there is no real cure. So it's used to, so medications are used to slow the progression. No cure for MS. Okay. Hopefully, I mean, I'll give you guys my own copy of this too if you guys want. Um, you can make it pretty or not. But yeah, I'll give you guys my own copy too after. Okay. Some other things is the some of the other medication, the Cytoxin is another immunosuppressive medication. So your sign and symptoms or side effect is increased infection risk. So for this one, you're gonna want to do some of the things, some of the patient teaching for this medication that you're probably used to is avoid the sick, avoid those that are sick, hand hygiene, wear a mask, avoid crowded places. Okay. Next, we have the steroids. For a lot of these autoimmune diseases, it's an inflammatory response. So things that directly affect that, your steroids are going to be effective. So this one, the prednisone PO is the maintenance. Solumedrol IV can be given for new attack. So this is a maintenance one. We'll specify Solumedrol IV, blah, blah, blah. This is like every Q to 6 days. And we'll say um, Solu high dose Solumedrol IV can also be given for an acute attack. So I recall that my patient that had the MOGAD, again, not the same thing as MS, but very similar. He was getting a bunch of steroids for the condition to help with the optic neuropathy, help with the acute attack that he had. And again, things to look out for when it comes to steroids is the increased infection risk. They're immunosuppressive. I would say also hyperglycemia. And if there are on high doses for a long period of time, think about your side effects of Cushing's because that's pretty much gonna be what you'll get from your steroid overdose would be a lot of the same things that you'll see in Cushing's. So that can include things like increased bleeding risk, changes in electrolytes. So you can get the hypernatremia, hypokalemia, increased blood pressure, change in mood, edema, stuff like that. Okay. So then next thing's up. Oh, my patient also got the IVIG. So that's another one that you'll see with some autoimmune conditions. The way that this was described to us was that this is essentially a decoy. So the IV works as a way for the body to be preoccupied with it instead of attacking the myelin sheath. But this is also, the IVIG is also a type of immunoglobulin, so it can also help with the immunity to some degree. So I'll kind of mention that. Ba, ba, ba. Yeah, but the main thing with this one is that it helps with these autoimmune conditions because the body starts going after these. Or at least that's the way it was explained. I don't recall if that's exactly, or it could just be a simplified version of it. Let me look it up. But at the very least, that's how he taught it, so that's how he'll test it. That was a hell of a lot of stuff. But yeah, the main thing is that it's going to neutralize some of your immunity. So here I'm reading that the IVIG contains a broad spectrum of antibodies that can neutralize autoantibodies and other immune factors causing self-tissue damage. It can block some immune cell receptors to reduce the activation of the immune cells and limiting some of the inflammation. So there's a lot of this stuff here. And it helps to suppress inappropriate immune response. So essentially just kind of know it helps with autoimmune. Yeah, he said that. I'm not sure how accurate because I feel like that's a little oversimplified. But maybe the fact that it's binding and neutralizing autoantibodies is kind of how he meant that. So I would just kind of, it's fine to think of it that way. You know what it's for, you know what the end result is, so that should be good enough for that. And then last C is I guess there's pain meds and these other stuff. Then there's but in terms of like main autoimmune type thing would be the plasmapheresis. So what this does is it purpose to remove antibodies and replace with new ones. So if the issue is the antibodies that it's attacking itself, then the plasmapheresis is gonna, for some period of time, help with that. So this is essentially a exchange of the plasma in the blood, or replacing the blood, essentially kind of like removal of some of the antibodies that are in there that's causing damage. Yeah. So, ba, ba, ba. As we mentioned, pain is one of your big things with multiple sclerosis. So here mention some things that can help with all that. So at oops, mentions adjuvant. So for nerve pain stuff, maybe like Neurontin or something or gabapentin. Things that can help with nerve pain. Baclofen, this is a muscle relaxant. So if the person's having some issues with s- weakness, spasticity, and all that stuff, hmm, for the back pain, the baclofen, this is a muscle relaxant. Yeah, if it relaxes the muscles, yeah, like Josh, yeah, constipation. So if it relaxes the muscles, your bowels are a muscle. so constipation, and then NSAIDs because they also help with inflammation and stuff. If they're having issues with hyperactive bladder, then the ditropan, this is also called oxybutylene, can help with that. And these two meds, the ditropan and the bethanechol, stop. You'll see again for the spinal cord injuries part of it. So this is oxybutylene. Yeah, I think this one's called Uricol or something. Urinocol, something like that. I don't think that's accurate. Let me look it up. Bethanechol. Uricoline, that's what it was. I just remember the uri, like urine. So I'm not peeing enough, so go pee. And then the col, because this is a cholinergic. Yeah, spelling check. And then the ditropan, I have to constantly get the bedpan because they're peeing. I don't know. Sorry, this is a cholinergic, not anticholinergic. That's what I meant to say. This one's an anticholinergic, so it has the same signs and symptoms as that. And this is acholinergic, which is why it has the word chol in it. So let's see. Because remember, cholinergic, though that's your rest digest. And that also helps with the ability to pee and stuff. While the anticholinergics essentially lead to more on the side of the sympathetic nervous system. So that's the fight or flight, which means you're turning off your rest digest and turning off your urine frequency to some degree because the body's not focused on some of those minor little processes. They're focused more on whatever's causing the flight or flight. That's kind of the intent between the two. And then lastly, it's just for the non-farm, similar to the Parkinson's, there's stretch and exercise because of the altered mobility. So for this one, it's again a lot on your management, your pharmacological, and then again some of your manifestations. So just kind of going back and comparing the two. This one's autoimmune, um, based on symptoms for the Parkinson's. Most of the time, the Lewy bodies do are there something that they can be checked, but a lot of time it's going to be based on presentation. While multiple sclerosis has a few specific diagnostics like your MRI to check the yes. Yeah, I'm gonna send it again. So I sent you guys one at the start. I'll send it to you at the end as well. Lumbar puncture can be done, and then more thorough neuro exam. The cardinal triad are like the main things that signs and symptoms for Parkinson's, while the fatigue, the pain, the facial pain, and the vision changes are some of your big things with your MS, as well as some of your elimination issues. So I'll highlight that one as well. And then we talked about the difference in the management, a lot of medical management for the autoimmune, and then a lot more pharmacological on the Parkinson's because there's not much else you can do other than the medications that improve your dopamine in the body, while your autoimmunes have so many different things going on. That's why there's so many different meds for this type of condition. Okay. So next we have ALS. Again, you don't gotta worry about the patho. really. Here I just kind of have written that it's due to rigid nerves. Um, the nerve cells become rigid, unresponsive, which leads to um, the changes that happen here. The lifespan for this one's going to be short because this one is going to lead to flaccid paralysis. So the body is just unable to move. This one's also called Lou Gehrig's disease. Uh, Here, they can do a muscle biopsy in order to see what's going on. They'll see necrotic changes in the muscle cells. They can do a spinal tap. And then all he said was definitive biomarkers and then didn't really go into detail. But again, I don't recall that ever needing to be known. So don't worry too much about it. I would say focus more on the physical manifestations for this one. But here are the diagnostics as he mentioned in the lecture. So here is just kind of the 3Ds. So this arthria, which is slow and slurred speech. So slow, slurred speech. Dysphagia, which is difficulty swallowing. We know that one. And then drooling. So this patient probably needs suction. They're gonna be risk of aspiration. And that's something that we'll go over for the management. Something that it's probably good to know is that their sensory is actually going to be okay. It's just their ability to move um, that's really impacted. And they're going to start to lose their motor skills first. So the fingers are going to go first, and then over time it's going to keep going. It's going to keep creeping up until you have that flaccid paralysis. But if you're having your muscles impacted by this paralysis, that includes your diaphragm. And if your diaphragm is paralyzed, then you can't really breathe. So that's actually going to be probably the key thing there. So respiratory failure and pneumonia are going to be one of the main ways that this person's going to die. There is no cure, but there is this medication here, the riluzole, which can slow down the disease process, but for some people it actually doesn't really have any improvement. So for some people it doesn't improve anything and it just kind of comes with side effects. So that's unfortunate. The main thing with this one is your liver function test. So uh, your AST, ALP, alkaline phosphate, AS to say ALT, AST, and ALP. Should be taking on an empty stomach and then avoid things. If you see these, just you can probably assume you want to avoid them for most things, or at least definitely the smoking or alcohol. The caffeine for this one's just because it has a drug interaction. I'll list the side effects for this one. Oopsies, that's not what I wanted. Here's a list of the side effects if you want to know. But I would say maybe like the main thing for this one is your LFTs and the neutropenia. So it's going to it's going to affect your white blood cell count. And maybe knowing that this is not a cure. So I think I've seen maybe some Kaplan questions where it's something along the lines of like patient education. You're teaching like the patient's family about the med, the patient's under the impression that this is a cure or whatnot. So that may be something that could come up. So knowing that um not a guarantee and it's only going to slow the disease down could be important. And everything else I highlighted. Oh, nice. So maybe we can highlight that one. So That's something that if he again if it's something that he mentioned, it could come up. That's the kind of test maker he is that he really wants to make sure that you listen to the lecture. So anything he repeats, things that he points out are things that could potentially come up on tests because that's how he does things. So and that if that's something he mentioned, then that's something I would keep in my brain for this one. So for this one, the pain meds, and this is done for contracture pain. So NSAIDs, Neurontin for like nerve pain, baclofen for muscle relaxant, and then the opiates. The reason why this is the last line is because it can, uh, because of probably like the respiration rate, the CNS depressant on someone that's already having trouble breathing. This is muscle relaxant, Neurontin, to help with the nerve pain, baclofen muscle relaxant, and first helps with contracture pain. Okay. And then your non-pharmacological is again focusing on that respiratory, so suction, um, assess for respiratory failure because that's one of the common ways they could die. Making sure that there's turn cough deep breathing because pneumonia is something that's common with them. Person might be on a one of these little ventilators. They might even be on a trach because they're having difficulties breathing, so they need help. If they're having issues, they're having that slow progressive uh, flaccid paralysis, then they're not moving. So that could mean that they are at higher risk for DVT. They're having probably trouble eating, so puree diet's something that can be done. But with this one, I would say focus on your respiratory management for that. So know that this person's at risk for respiratory failure, I think is your key thing with that. I could see sensory come like those kind of weird questions where it's like you have to know that the sensory is fine. But it's just like the movement. I don't know. The Kaplan has some really weird questions, but maybe stuff like this could be important. Just like knowing that it's the loss of the fine motor skill, so your fingers and it slowly moves up. Okay, and then lastly is myasthenia gravis, another autoimmune. So again, the pattern here is that the both of the autoimmunes here don't have reduced lifespan, but they do have the decreased uh, quality of life. Diagnosed mainly from symptoms and then the tensilon test as well as the um, antibodies are going to be high, which you would expect because this is a autoimmune. The tensilon test is essentially giving someone the medication that would treat this condition, and if it helps their condition, then we know that that's what they have. We'll talk more about the stick mines. So the stick mines are going to be um, is a cholinergic medication. Ba, 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 ba. Okay, which makes sense because this condition is a lack of acetylcholine. So cholinergic directly impacts the how much acetylcholine it impacts that part of your sympathetic nervous system, your parasympathetic nervous system. So it makes sense. You're lacking this, so you get cholinergics. Okay. because the cholinergics are associated with that parasympathetic as opposed to your sympathetic. Remember the para, like you want to think of like paralysis, so you can think about your rest, digest. Think about the opposite of fight or flight. So it's going to lower your BP, it's going to lower your heart rate. So with this one, your key thing is that you want to assess for the myasthenic crisis. So this is where their um, too many cholinergics leads to this severe hypotension and severe drop in heart rate, and then atropine, which is an anticholinergic, is the antidote. So that's the things that I would keep in mind is understanding that oh, there's also one more key thing with this one that we'll talk about for symptoms, but other than that, I would say know your tensilon test and know that this is a cholinergic medication. So because it's cholinergic, it's going to potentially cause this myasthenic slash cholinergic crisis where your BP and heart rate are decreased. And then your antidote is your atropine, which is your anticholinergic. Oh, let me just make sure I didn't speak incorrectly about something. Sludge. I actually don't know the sludge one. Oh, I think this shouldn't be in the area. Should be here. There we go. That makes more sense because this is a cholinergic crisis, not a myasthenia crisis. It's opposite of anticholinergic sludge. Salivation, lacrimation, urination. Oh, interesting. Yeah, yeah, yeah. I like that. So yeah, so here is something that's a mistake. It said myasthenic crisis. This is referring to this right here. The decrease in heart rate and BP is referring to a cholinergic crisis from too much medication because you're giving too much cholinergic. So it leads to decreased heart rate and BP. And then the atropine is still the antidote. So that's everything mentioned here was correct, just the name. It's not a myasthenia crisis, it's the cholinergic crisis. But there is such thing as a myasthenic crisis that is actually listed over here. So that was a mistake there. So we'll make sure that there's no confusion by the end of it. So here's some of the manifestations again, the fatigue and the weakness that come with autoimmune conditions. For this one in particular, if we look at like myasthenia gravis on a lot of pictures, you kind of see a lot of the same appearance where you have this eye drooping and it almost kind of looks like someone had a stroke. So a lot of very similar looking presentation. They kind of look like they had a stroke almost. So the eye drooping, the facial drooping. But I think a key thing here would be these two things right here as well that differentiate these a little bit more than some of the other ones is that this person has and there's dysphagia here too, and I think that's a key thing to keep in mind for sure. But dysphagia as well as diaphragm weakness. So this person's at risk for airway issues, aspiration, and stuff. So if I recall, for your some one of like your prioritization slash I think delegation questions, I think one of them was like myasthenia gravis patient that suddenly became confused or something. Like suddenly it was something where like the myasthenia gravis was causing some sort of airway or breathing up like breathing issue. I don't know if you guys remember that. I think I've referenced this before. Let me see. Let me see if I have it still. Transformers, robots in disguise. Was that leadership week? Oh, there it is. I have it. This was from your guys's in class. Unless they didn't do it this time around, but I imagine they still did. Let me know if they did or didn't, just out of curiosity. Here's what I was referring to. It's like client with myasthenia gravis has a sudden difficulty talking, and that kind of comes from the airway issue, and that's something that I think is key for myasthenia gravis is the airway issue, breathing difficulty. That'll kind of go together. So here's what it should have said before. This is the myasthenia crisis. This is the exact opposite condition that we had before. That's why I wanted to make sure that I clarified that this was an error because the myasthenia crisis is essentially when the lack of acetylcholine is really pushing your body into that fight or flight. So essentially, you want to think about how acetylcholine is parasympathetic. So if this condition is deficient in it, your body's going to go instead into the sympathetic, which is your flight or fight, your fight or flight. And fight or flight means increased BP and heart rate, which is why the myasthenic crisis is exactly what you're seeing here. Okay. So not to be confused with up above the cholinergic crisis, which is when you're giving your medication for this and then you kind of go too hard the opposite way. You overcorrect it, and now you have the opposite, which is decreased heart rate and blood pressure. Is that making sense on that? I just want to make sure we're clear on that. Cool. Cool, cool, cool. And then can you repeat? Yes. Compensatory response. Which one? If not, I can explain some more. Myasthenia crisis. Not so much compensatory, it's just kind of the way to think about it is, and this is like some pathos stuff to some degree, but it might help kind of understand. This is more like pathways, so I don't really care too much about this. Actually, maybe I do actually. You have the parasympathetic versus the sympathetic system. I like to think of sympathetic as just like your fight or flight, and your parasympathetic as your rest and digest. Um, your acetylcholine directly manages the parasympathetic system. So if you are your body has a balance of acetylcholine as well as norepinephrine, which manages the sympathetic nervous system. So it has that balance that keeps your body. Yes, yes, yes. So your myasthenia gravis, you're deficient in acetylcholine, which manages the parasympathetic. So because you don't have enough, that balance is thrown off. So instead of being here in the middle in like a nice little balance, you don't have enough of the parasympathetic, so you start going closer to this side. So myasthenia crisis means that your myasthenia gravis is causing a crisis because you're going so far this side that you're having the increased heartbeat, you're having the increased blood pressure, you're releasing more adrenaline, your body's going to hyperdrive. Okay. Yes. And then here, the cholinergic crisis is because again, you're giving because you're over here, your body's over here, not enough acetylcholine, so you're over here. You're giving them acetylcholine, so you're going back towards the middle. You give them too much of your cholinergic medication. Cholinergics are the medications that increase your acetylcholine and that impact your parasympathetic. So now you go too far, and now you're having the opposite issue. So that's kind of like when you're rehydrating a patient that was dehydrated, and then you give them fluid overload instead because you were giving them NS 150 ml per hour for like 4 days and like 4 days straight. So essentially, too much medication causing an overcorrection. And then when this does happen, so when your stigmines, so your medications for this condition, get to that overcorrection point, your atropine is the antidote. Um, so that's what's going on there. Yeah. So that's another thing. You'll learn about atropine when it comes to your ACLS. You don't really do ACLS, but you learn some EKG stuff. So yeah, your bradycardia gets treated by the atropine. Your atropine in general gets used for for cholinergic crisis. But you also see it in you'll see this medication come up again for in 240 for your um, symptomatic bradycardia. So it helps increase your heart rate, which is one of the issues here. But it's also going to be kind of counteracting the stigmines, the cholinergic. So for this one, having a little of that knowledge from like your pharmacology helps, or at least the pharmacology that was done over the summer. I don't know if you guys aligned with that. I think by the time that was offered, you guys might have been done with your two pharmacology classes, and I don't know if Brooks covered it. But I guess it also required you to read the book, and I'm not gonna lie, the pharmacology book is the only book I've actually read in the program because it was like an easier read, so I actually liked reading it. The Iggy book is so the Iggy book is just so dense, I don't like reading it. I'm getting a call. Let me just take this for a second. Okay, I'm back. Okay. So here with your pharmacological management, um, the mestinon, which is your pyridostigmine, uh, I like to think of these just as the stick mines. That's like the ending. So I just think about the stick mines. There's different types of stick mine medication. They're all cholinergics. Here's the main one here. He references the period of stick mine, but I just memorized the ending just in case. But like we mentioned, some of the signs and symptoms are bradycardia because we're going into um because it's a cholinergic. So yeah, you're going um into this side of the pathway. So lower your heart rate, lower your blood pressure. We said atropine is the antidote. So that's just gonna be it with that. Because it's again autoimmune, so you'll see the prednisone come back, the IVIG come back, the Imuran, which is also a DMARD, I believe. Let me double check that. I guess he didn't really explain that one very well, but it's just an immunosuppressant. I believe it's a DMARD. Just gonna look it up for fun. I guess it doesn't really matter. I guess I can also treat MS. That's interesting. And lupus. Cool. And RA. Cool, cool, cool. And then we mentioned IVIG already. He did mention the thymectomy. So this is removal of the thymus, which is something that is used to establish the immune system, but again, not too much. Don't have to focus too much on this one. So not to be confused with the thyroid, the thymus is over here instead. Yeah, don't worry too much about this one personally. Just the thing to I guess that could be good to know is that look at the position where it's in. Um, if they're removing it, it makes sense that pneumothorax or hemothorax are possible complications. So maybe I'll include the little picture. It may or may not be too visible, but maybe it helps. You can kind of see the little thymus over there. So just based off positioning, uh, can remind you that these are possible things that can happen. And the rest for the non-pharmacological is fatigue again, fatigue. So your rest schedules, assisting ADLs, um, all of that stuff that can be effective. Energy conservation, rest periods. But I think something that's important to keep in mind is the aspiration risk for this person because this person can aspirate. They have dysphagia. So airway breathing, I think, are things that you really want to think about. So risk aspiration and impaired breathing pattern. At least when I was doing practice questions, I felt like all the practice questions from like nurse labs or whatever, I was looking questions up, Quizlet, whatever. A lot of the MG questions were more focused on like aspirations and impaired breathing more than anything. Um, but yeah, that's kind of that. The Kaplan test too, yeah. So that's that for that. I'm gonna then overwrite that one and send it to you guys now, and then we can go over the spinal cord injuries. Okay. Okay. So then here's just like a quick little preview of stuff I have. Hopefully we can get through everything. It'd be for the best if we get through everything today. I think the people they close at 9, it's currently almost 7, should be okay. But here I just have a list of types of injury because some of the stuff can be kind of fluff. Like you don't have to know every different type of injury. They're just examples for context. So I just kind of wrote it down because it's not too important. Don't bother memorizing all this stuff. It's just examples. So you can read that on your own time. But again, just examples. Don't worry too much about it. Something that I think maybe could be important is just kind of the difference between incomplete and a complete spinal cord injury. So if you have a complete spinal cord injury, that means you're lo having a loss of motor and sensation. But when it's incomplete, you can keep one or the other. So you could have a motor incomplete, meaning that you keep some motor, but you just can't feel things, or a sensory incomplete where you can feel things, but you can't move things. I would rather have this one because at least I can move it. And I guess I wouldn't feel the pain or nerve pain, maybe. Maybe there's like that phantom pain, but this one seems more tolerable to me than not being able to move it and I can still feel it. And here is just kind of, and it kind of goes along with this picture, just again for context. So again, for context, and then when it comes to some of the conditions where it's like, oh, it's above C5 or whatever, injuries above C5, above T12, you can see that the way the way it's numbered, smaller number goes up. So it goes C, T, and L, and then I guess S for your sacrum. So yeah, 1 is at the top, 7's at the bottom. Then we go start here again at 1, and then we go 12. Just so you have that context. So when you're seeing the thing that says anything above C5, you're not thinking C7. Just because the number 7's above 5, you're thinking above position on the spine. So that's 4, 3, 2, 1. Okay, and then again, for more context, what does the spine do? So that's, again, for context, don't worry too hard about it. You're not going to get asked anatomy questions. But here I do have the levels of injury. So that's some of like the key ones that they go over. So here, between the C3 and C5, uh, in terms of here, it seems like they emphasize C5 a little bit more. From I think outside questions, I think I see 4 and 3, like above 3 and 4 a little bit more. So again, above C3 to C5, meaning this portion here, this portion here of the cervical spine. So anything above that can have breathing issues because that area leads to some of the nerves that control your diaphragm. C1 to C8, so anything that's hitting the um, cervical spine is going to lead to quadriplegia, meaning anything. If you have an injury anywhere here on the cervical spine, that means you're no longer able to move. And I have a picture for it here. You're no longer able to move your anything. Your head only. Everything else not going to be there anymore. So that's your tetraplegia, quadriplegia. T4, T1 to L4. So again, that's going to be T1 all the way down to L4. If you have an injury in that area, so there's a huge area, that's going to be uh, various levels of paraplegia. So you can kind of see that, like, with your underneath your T12, like you can see T12 here. Um, Anything below that, you lose your legs. And anything above that, it would still be the same thing. It's all up until you hit this little sweet spot here. You still have access to your arms and stuff. You don't lose full access to your arms up until this point right here. So up until T2, T1, you still have access to your arms. And anything above that, quadriplegia. Or at the very least, like varying different levels of well, actually no, paraplegia. It's just that the C4, C5 above, that's when you have diaphragm issues. Let me go back to the proper zoom. With tetra, you have flaccid bladder. You should have, yeah. Yes, because that's above the injury is above it's not at the top of my head, but I believe you're right, yes. I think it was like above here I have it somewhere. Above T12 or below T12? Above T12 is spastic. Above T12, below T12 is flaccid. But with tetra, you have flaccid. With tetra, it'd be really high, so it'd be the spastic bladder. Yeah. Spastic meaning that it's um involuntary contractions, incontinence, basically, yeah. And then the flaccid one is the one that is no contraction. Yeah. I think I had a way of remembering it. Yeah, it's based on T12. Well, we'll get to that when we get to that. But I do have a way to remember it. Yeah, but that's kind of that. And that's, again, context. So here we'll just talk about some diagnostics. Um, just kind of know in general your ABCs come first. So like when you're seeing the patient, first things first, you're gonna go ABCs. Otherwise, X-ray, CT scan to assess damage to the spine. CMS, yes. So that's the sensory testing. There's a few like different tests that can be done. So the CMS, there's deep tendon reflexes. We'll talk about that a bit more when we get to spinal shock, pupil responses. So like just in general, brain injury, we'll have fixed pupils and just some issues with like pupils. So one dilates, one doesn't. Like level of consciousness. So that's kind of going with your Glasgow coma scale. So we said CMS, we said, yeah, so that's involves touch, motor, circulation. So that's kind of the general idea. So focus on ABCs. They can do these diagnostics for assessment of damage, CMS, motor movement, ability to move, feel, deep tendon reflexes, pupil responses, level of consciousness, and something basic also like your vital signs and stuff. So then I think the thing that's gonna take up a little bit of time would be kind of getting the systemic complications into account. But we can see if I can find a way to kind of simplify it and kind of get it down to more big picture ideas. So I kind of just broke it down now into manifestations versus interventions. So in general, just kind of think of it as things are with your spinal cord injuries, like things are usually going down typically. So you'll see things like decrease cardiac output for this, decrease gas exchange, ineffective breathing. Usually you'll see like paralytic ileus on this one. And then you also have like the bowel and genital urinary, depending on like the positioning of the spinal cord injury, and things like that. So just in general, you can kind of think of it like that as a way to kind of cluster things down. So I would just kind of mention this kind of like decreased cardiac output. So hypotension, bradycardia. Like I said, in general, think of things decreasing and going down. So we'll say venous pooling, which means that as some of your interventions, you're gonna be trying to maintain the map. Um, he mentioned specifically 85, prevent DVT, so like heparin, Lovenox, SCDs, other things to deal with your hypotension include IV fluids for hypotension, IV dopamine for hypotension, IV atropine for bradycardia, which we talked about a little bit when we were on the chronic neuro part. So again, here you can kind of see everything goes down. Decrease cardiac output, decrease blood pressure, decrease heart rate, decrease venous return. So everything decreases, things go down. So your interventions is going to be maintaining the map, preventing DVT, and then treating the symptoms. So hypotension, IV fluids, dopamine. Dopamine is going to increase your blood pressure, going to increase your heart rate, and then atropine directly we talked about helps with that heart rate as well. Okay, so then respirations. So we're going to have um, manifestations like ineffective breathing patterns, impaired gas exchange. Yes, so atelectasis. So this is going to be um, one of the potential things because if they're not able to move, they're having difficulties breathing. This person's potentially going to need to be intubated. So ineffective breathing patterns, um, lack of ventilation. So might need and especially so especially if um spinal cord injury is above like C4, C5, neurogenic pulmonary edema. So that would be like what was that? I guess it'd be like I don't know, I'm kind of think of like neurogenic shock, but it doesn't really it's like some sort of inflammatory response due to the brain leading to the fluid shifts in the pulmonary. So yeah, but I think the main things here like atelectasis, pneumonia. Sure, I don't really know too much about the neurogenic pulmonary edema. Not at the top of my head, at least. So I'm gonna look that up. I have an idea of what it would be referring to, but let's take a look. If I had to guess, it's due to inflammatory response. Oh, okay, that makes sense. Yeah, that makes sense. Okay, so the reason it's neurogenic is their body's releasing catecholamines. So catecholamine, so that's something that can happen with so something that can happen in sepsis is your body compensates from the sepsis by releasing catecholamines. Catecholamines is referring to norepinephrine, epinephrine, dopamine, and all of those can do things such as cause dysrhythmias, and it can also, and I guess in this case, lead to fluid shifts due to all that stuff happening. So I guess that's it's interesting there. We're learning things. Cool. Pulmonary, interstitial, and alveolar. This one interests me. Ah, well, can't look at it. Okay. Well, yeah. So that's kind of what that is. I would just say don't worry about the patho, just pulmonary edema. That's all. That's all you got to focus on this part. Just focus on this part here. Don't focus as much about the reasoning why. You're not going to get tested on the reasoning why. As you could tell, I didn't know it either at the top of my head. So you're not going to need to know that. I don't even remember. Like, I didn't even remember that being a thing. So I don't think it came up on anything. But I will ask you on the intervention. So what are some things that you think will be helpful on someone that has issues? Big and frothy sputum. That's something that can happen due to the pneumonia and stuff. Big and frothy sputum. Yeah, so turn cough, deep breathe, head of the bed up. So think about your typical respiratory stuff. So you said this person's gonna probably be on a ventilator. So maybe review ventilator. Some of your VAP bundle, your ventilator bundle. Yes, so suction, perfect. Yep, so I like that. Head of the bed up, but you can also help with postural drainage and just a lung assessment, lung sounds. Suction, ventilator, um, ventilator care. So that includes suction on its own, includes oral care, sedation, vacation, suction PRN, suction PRN, oral care, Q 2 hours. Oh, I already mentioned oral care. Oops. Cool. That's pretty much that. So I will include for the people that want to know why. So sympathetic response. Cholamine, so that's dopamine, epinephrine, norepinephrine. Yeah, so for the people that want to know why that happens. So like I said, this happens in sepsis too, the catecholamines, although it's in that case the catecholamine release there is more associated with dysrhythmias. So it can lead to cardiac dysrhythmias. Sometimes sepsis can lead to heart attack. Um, and then vice versa on that one. So the heart attack, I don't know why I said vice versa. That's like the second time I think I said that. I don't know why my brain says, yeah, must be vice versa. It doesn't make any sense. No, the sepsis can cause MI um, due to that. But that's good. So in general, you kind of see like things go down. Another one where respiratory things are less effective. So we just everything impaired. So here you can cluster it as everything goes down, impaired gas exchange, impaired breathing. Um, you have crackles, atelectasis, fluid shifts. So far it's kind of just been everything going down. So with the GI, you have the paralytic ileus. So that's decrease in your movement of your bowels. So you're gonna assess for bowel sounds, assess for distension. The main thing with that is your obstruction, because obstruction can lead to the perforation, which can lead to shock, infection. Person can get stress ulcers because they're MPO and stress. Well, obviously, because that's in the name. They could have GI bleeds due to the stress ulcers. Um, but also because they're on steroids and they're probably going to be malnourished. So for that one, kind of just, yeah, I guess this goes here rather than there. It's kind of assessment of bowel sound distension. Uh, uh, um, PPI or H2, so Protonix IV to prevent stress ulcers, for example. Uh, uh, um, and then for the other one, just assess or monitor albumin for nutrition, potential TPN. So for this one, how can we like cluster this into one? Eh, it's kind of just like everything goes to shit, honestly. Bowels slow down, ulcers, bleeding. It kind of is just like everything bad happens. Pretty much for all of these, just like everything bad happens. Seems to be like the re reoccurring little thing. And we'll think of it later. For bowels, here's where you have some changes like depending on if it's above or below. So we have above T12, below T12. And the way I think of it is, I think of it like the word above, I think of things going up. So when it's above T12, they call it a reflexive bowel. So essentially incontinence of bowel. So the pooping goes up. So I just think of it like pooping. The pooping is just coming out. Everything goes up. Pooping is coming out. And then below T12, I think below, so things slow down. So this is a flaccid bowel. So flaccid bowel, essentially like a constipation, unable to get rid of it. It's stuck. So that's kind of how I think of it. So above T12, that kind of think like hyper versus hypo. So I think of hyper bowel, above hyper bowel, below hypo bowel. So hypo as in slow constipation. Um, but yeah, it's kind of like the main thing with that. The only real intervention is just kind of potential may need to do like digital disimpact. So like physically get that poop out. Diet changes. So include fluid, 2 to 3 liter a day, and fiber, stool softeners. At least for the when they have the flaccid bowel. Yeah, probably. Um, there's also like the bowel schedule they say. So similar kind of like the urinary schedule. Similar idea. Yeah, the suppository. So this is if they're most of these are kind of like for constipation now that I look at it. It's constipation, 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 constipation. There's a little rectal stimulation or the glycerin suppository. So for most part, these are just kind of like if they're constipated. If they're incontinent, I guess you're just gonna have to clean them and just make sure that the skin breakdown's not too bad. Not really much else you can really do. Because at the same time, um, their incontinent of the bowels is because the lack of sphincter control, as opposed to like necessarily like hyperactive bowel. So this isn't really hyperactive bowel so much as it's just like the sphincter is open at all times. Because and as we see before that you have paralytic ileus, so the movement through that through the bowels on the slower end, it's just that the sphincter can't keep it in, so it's um just coming out. They can't control it. Colostomy maybe for these patients. Uh, Probably that makes sense. It would definitely help with like infection and skin breakdown and stuff. Okay. And then urinary. Similar idea with this one is split it up into above T12 and below T12. So above, I think of things going fast, things going up. So I would say the spastic reflexive bladder. So again, incontinence. Below T12, I think below hypo. So this is flaccid bladder. So this is essentially retention. So here they match. They're having essentially the equivalence of each other. And again, above hyper, like things coming out on its own. Above hyper, things coming out on its own. Below, things aren't coming out. Typo, things aren't coming out. Okay, so that's kind of like the main thing there. With this, you're kind of worried about things like like UTIs and stuff. So increase risk of UTI, whether they're incontinent and just peeing themselves, and then the like again, if they're just peeing themselves, same idea with like the poop. They can get into the like be around the genitals and infection. So whether they're incontinent or they're retaining, this is either like they pee and then the pee is like in the near the genitals and they get infection that way, or here they're retained, so they have like a UTI from the bacteria, like from the urinary stasis. So either way, they're at a risk of a UTI, and potentially also with the retention, they might be at risk for some kidney stuff, just because the kidneys need to be properly, like you need to be able to remove the urine. If it's stasis for too long, it can get into the ureters and that could get into the kidneys. We talked about the hydronephrosis and whatnot. We can do a condom catheter or IC intermittent catheter PRN. Yeah, that's good. I believe he mentioned that in the acute phase, maybe like a Foley catheter, but this person's gonna need to be on it. Like, they're gonna need something for life. So whatever we can do to decrease in UTIs and stuff. So in terms of the intervention, we mentioned the ditropan, otherwise known as oxybutene, used to, this one's used to slow down bladder. I guess what's like, I want to see what's the best way to say it. Used to, I guess that would make sense. So it's treat incontinence. Sorry, did I just say the wrong thing? Sorry, I meant treat. Um, I guess that's right. Yeah. And then this one's the methanochol uricoline. And this one's there to speed up. I guess kind of just like enhance bladder movement and treat retention. The Creed method is pressure. I believe so, yes. It's to push down on the bladder to try to get urine out. So that's something. So the Creed method. Yeah, it's pushing down on the bladder to squeeze urine out. If they are having some, I mean, I guess they can't really do much with that. It's just kind of other things that you would do would be kind of avoid infection. Don't they also do surgery to add on to the size? Oh, the bladder augmentation? That's a possible thing, yeah. Although I wouldn't focus too much on it. Like you can look it up, I guess, if it's interesting, but I would focus more on the medications for this one than anything else. Heard him kind of say something. Yeah, maybe. I mean, you know that it's a thing. Yeah, yeah, yeah. At most, maybe it's like a random answer choice on a SATA, but nothing too major to stress over. So increase fluids because your kidney needs fluids. It's also like a bladder training. You'll see that as a answer choice, the bladder training stuff, the bladder regimen, urinary regimen as a popular answer choice for like some Kaplan questions and stuff. Okay. Any questions on anything so far? Because we did go through a lot of content. But again, try to focus on big picture stuff. A little bit less on the hyper specific stuff. Because remember, there's no fill in the blanks on that test. So as long as you're just able to recognize what's going on through the answer choices, you'll be okay. Okay. So with musculoskeletal, it's more like contractures, muscle spasticity, bone loss. So fractures, because if you're not using it, you're losing it, which also means muscle atrophy as well. And the intervention for that would be like doing range of motion exercises for them if they're not able to move the limb. CMS checks because anything musculoskeletal, just think CMS, think six piece. uh, CMS six piece. That will kind of get you going and just kind of proper alignment. There's other things like the trochanter rolls. I haven't heard that one since like literal first semester. Splints, footboards, and then skin wise. So their issues are going to be um, risk of skin breakdown. So if they're why? Because they're immobile, that's huge. Moist if they're incontinent, they're going to be malnourished. So all of these increase their Braden scale. Their Braden scale. Or is it increase or decrease? I think decrease. Is it increase or decrease? I think it's decrease. Yeah, I think decrease. Yeah. Well, the point is, it's going to make their Braden scale bad, and it's gonna automatically fill in your care plan when you fill that thing in and tell you to do other stuff. Intervention. I think it's lower. Let me see. Let's find out. Lower. Yeah, lower. Higher is better. This is on Facebook though. Were you gonna trust Facebook? That's the one that we use here. Yeah, the higher number means low impairment. All I know is I remember clicking through this. I was like, okay, are they moist? I don't think so. So I just clicked the four. They walk sometimes. Boom. They look like they eat. Boom. Three or four. Yeah, Braden High is good. And then just keeping the patients clean and dry, which is easier said than done when you have like 4 to 5 and person's pooping, incontinent of bowel. There's like one other one's like sexual dysfunction. They're not gonna test her on that. They didn't even mention it. Uh, there's also like psychosocial that can happen, but again, they don't really test too hard on that. And if they do, it's like the most obvious thing ever, where it's like, yeah, like anger, denial, stuff like that. So instead, I want to focus more on the intervention and some of the possible complications. So the spinal shock, neurogenic shock, autonomic dysreflexia. I think this is um, things that you can definitely expect to have questions on. So if you are on, I think they use like a minimum of Kaplan. Definitely go through whatever they have on Kaplan for this. But for the most part, I think I remember studying nurse labs a lot for this test, or at least for the spinal cord injuries. I remember because this is like it's not last second, it's week 8. It was like week 8 content, but it was like the last content before the final. So it was the one I knew the least. So I was like, oh dude, I don't get it. But then when I was kind of doing some questions, it kind of was like, oh, it's not that bad in terms of like the questions. And that again, I don't recall the questions being too bad. So it's more straightforward than you might think initially. Because you do have to think about this stuff here, but again, try to just big picture this stuff. Really want to think about big picture for those systemic changes, big picture stuff. And then use your brain power a little bit more for intervention and management of the conditions. Okay. All right. So now I'll have you guys list me some interventions and we'll write them all down and talk about it. And we'll see if we can get out. I think we can get out by like eight something. Should be okay. All right. I'm gonna get some water. Type in the chat like interventions for like what's important for someone that has a spinal cord injury. I'll be back. All right, let me see what you guys got. You guys got a lot of good stuff in there. Huh? Yeah, I like that. So, um, early, immediate immobilization. You guys mentioned the log roll. I like that. So potentially also maybe like a cervical collar, log roll. So, to prevent twisting of the body, basically just kind of make the assumption that someone goes down, maybe they damage their spine. So just kind of treat it that way. Because if you're being a little rough, then um yeah, because if you're being a little too rough, I kind of wrote that wrong. Because if you're being a little too rough, then maybe you can worsen the injury. So kind of just assume spinal injury until proven otherwise. Um, let's see, solumedrol, yeah. So that's a big one there. Is going to be your IV. Solumedrol is going to be something that you do because as soon as the spinal cord injury occurs, there's going to be a large inflammatory response that your body does. And the idea is that without the solumedrol, that the secondary injury could happen, so that inflammation causes even more damage. So good. What else do we say? It says for touch and sensory. So CMS. So basically, um, ABC, CMS, especially for C4, C5 above C4, C5 injury because that can lead to respiratory dysfunction. Solumedrol because it helps to prevent secondary injury. And it's within 8 hours. Prevent secondary by reducing the swelling. We all know the signs and symptoms of solumedrol at this point. Good. I think that's perfect. He did have, I guess he mentioned like the halo brace and like the pin care and stuff, but I don't really know if that actually came up. Refresh the signs and symptoms? Oh, okay. So, side effects would be your hyperglycemia, reduced immunity. Those are the main ones you want to really think about. But over time can cause your electrolyte imbalances. I think about your Cushing's. Just think like always think like Cushing's because that's when it's high dose, high for long term. That's kind of what it's kind of leading towards. So we're going to lead towards some electrolyte imbalances, edema, increased risk of bleeding, bruising. So I'll put some other information I have. I have some information on like halo braces, but I don't recall if he really went hard on it. I don't think he did. I don't recall it actually coming up at all, if I'm being honest, but I'll include it. So on the halo brace, clean the skin under the vest. It would be the opposite. So it'd be sodium up, potassium down over time. So the way, if we recall from Cushing's, is that um, yeah, so it starts to affect the aldosterone receptors. So um, because of that, if we recall, aldosterone, its purpose is to retain water. Oh, sorry, retain salt, which indirectly retains water, um, and then release potassium. So with your soluble starts affecting that aldosterone, activates it more, so it leads to this right here. So over long periods of time, so long-term high dose. This person probably wouldn't be, but that's just like just a refresher. In terms of like short-term things that will come up that you will watch out for is more about these two. This person's already at a high risk of UTI, so the fact that they need to be on steroids probably doesn't help their case. And then the hyperglycemia could have an impact on like no healing in general and all that stuff. Yep. So what else do we got here? So yeah, again, I don't recall the Halo brace stuff coming up, but in case it does, it's listed here. Kind of just goes over like the pin care. So clean with the gauze, remove anything crusty around the pins, assess for redness, swelling, drainage, infection. Something I think he did mention was like if you're doing CPR, you know how to remove part of the vest to do compressions because the Halo brace kind of looking like that. So it can't really do compressions if any idea how often to assess pins? I don't think he mentioned it, and again, I don't think this even comes up. It's just like extra information he gives out. I don't recall it ever coming up. And I honestly don't know how often. Q4 sounds pretty solid to me. That might even be too much even, but like it doesn't hurt. Let's see. It might be more of a like once a shift thing, maybe. Not particularly sure. But again, don't need to know too hard on that. So I would say don't worry about it. Okay. So now I just something stupid. There we go. Now it's going to be on these three conditions. And again, I think your meat and potatoes for this is going to be the these three conditions, knowing your general intervention. So you're definitely going to get a question. I feel like you're definitely getting a question where you're going to give IV Solumedrol or IV Solumedrol is given and like why is it given? Whatever. And then again, big picture idea when it comes to um, all the different changes because there could be some questions that are like a person has an injury, a spinal cord injury. Um, what are things you want to do? And then you kind of have to think about these things. But again, there's so much detail. That's why you need to big picture idea. Okay, so now let's just go into specific stuff. So here's the spinal shock. I did provide you guys a definition. It's just a temporary suppression of your deep tendon reflexes, a loss of sensation immediately after a spinal cord injury that can last hours or weeks. And it's going to be a flaccid paralysis below the site of the injury. So then when it comes to that, what are your interventions that you do with your spinal shock? So this is what, again, I expect you to have your bulk of questions on these three things. Yep, so you're definitely going to do your IV corticosteroids immediately within 8 hours. Immobilization, do like that. So again, always assume spinal cord injury when you can. Keep immobilized to prevent secondary injury. Secondary injury. Yep. So when is it considered done? You guys kind of indirectly answered it, but that is when return of deep tendon reflexes. And then I'll just include ABCs here. So it's kind of like I wouldn't say obvious, but like it's like in general, just always think ABCs for everything that in nursing school. Rule them out first and then move on. Uh, yeah, just ABCs. Remember that C4 above C4, C5, they can have breathing issues and stuff like that. But I think your key thing here is just knowing uh these interventions, just kind of understanding these, understanding that's the return of the deep tendon reflexes that shows you when it's considered done. Okay. And I think also key noting that it's flaccid paralysis. You do have some degree of flaccid paralysis below the site of injury. But because of spinal shock, we're not able to directly know. So that's kind of one of the key things is that we don't really know how bad the injury actually is until the spinal shock resolves. So maybe you might have like it's possible that they could do like a sort of like patient education question on that. But again, your key thing here I think is that uh return of DTR and your interventions. All right. So now for this one, your neurogenic shock, I have it as a fill in the blank. So it's a manifestation of um three things that were mentioned, but I would say two are more important than the other. But so what three symptoms? I'll give you one just because that one the other one's kind of weird. It's just kind of warm, dry. And then two key symptoms here. Yeah, hypotension. So it's still a type of shock. So hypotension and bradycardia. So the unique thing about neurogenic shock is that every other shock naturally has tachycardia for compensation. This is I believe, the only shock that it has bradycardia because the brain is not able to, you have that spinal, like that disconnect between your nerves due to the spinal cord injury. Um, your body's not able to properly compensate, so you have that shock, that hypotension without the compensation. So you have bradycardia, hypotension. And I guess it is kind of a unique thing here. You can have warm and dry skin, I suppose, as opposed to like other shocks where you have your cool and clammy. So I guess that's some differentiating factors there. So, and I mentioned here, it's usually caused when there's an injury to T6 or above, leading to the loss of sympathetic stimulation. So again, we were talking about the sympathetic nervous system, how it causes management of your heart rate and blood pressure. And if it's stimulated, it increases heart rate and blood pressure. So if you have a loss of that stimulation, it's going to cause the opposite. So similar to that cholinergic crisis, you're going too much the opposite direction, and it leads to hypotension, bradycardia. Okay. So what would be your interventions? I don't know what I did. So what would be your interventions for hypotension and low heart rate? You'll notice that this is some of these can be very similar to stuff we talked about. So IV atropine, similar to that chronic neurocholinergic crisis. IV fluids for the hypotension. So IV atropine to treat the bradycardia. IV fluid to treat the hypotension. What else? What else can be effective for someone said raise the head of the bed. I don't think it's definitely not bad to do so, but I guess yeah, but it's not bad to do so. I wouldn't mind. So what else could be good? for blood pressure. I believe we talked about it in another one as well. Vasopressors, yeah. So the ones they mentioned here are dopamine and Levophed. Levophed is norepinephrine. You don't have to worry about the specifics on each one. They technically impact the vital signs differently, but you don't have to know that. Just kind of know them as vasopressors for now. You'll get more specifics in 240. Okay, perfect. That's kind of all I really care about here. Cool. So again, key thing is knowing this, because especially if you're thinking about your other example of shock that you guys go over, the hypovolemic shock, you'll notice that these two here are different than your typical hypovolemic shock. Every other shock will have tachycardia. This is the one that has bradycardia. Most other shocks will have cool and clammy. The only ones that have warm and dry is sepsis and well, I guess sepsis might be like warm and maybe clammy, but this one supposedly here says has warm and dry skin. So that's another key difference. Okay, then lastly, it's your autonomic dysreflexia. So I have your definition here, medical emergency. This happens when a strong sensory input is carried into the spinal cord via some of the intact peripheral nerves. That sensory input will travel to the spinal cord. Um, well, it's by some of the intact peripheral nerves. It's going to trigger a reflexive sympathetic surge. Essentially, it's a sensory input from somewhere below the injury, from some of the intact nerves. Your body receives that input and starts freaking out. That lack of connection. There's enough connection for that to have for it to have a sort of reflex, but not enough of a connection for it to manage itself. So it causes a essential freak out of the sympathetic nervous system. So this is going to be something where, again, I think I have it to, I guess here, blah, 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 blah. Well, I guess, sure. I have this as a fill in the blank. So this is going to cause vasodilation or vasoconstriction. Yes, this is gonna, so we'll put, just make sure. Yeah, it's gonna cause vasoconstriction. So recall again, we're triggering the sympathetic nervous system here. So we are going back to this parasympathetic nervous system little picture. We are triggering the sympathetic nervous system. So that means we are fight or flight. So that's going to cause increased blood pressure. Um, it's going to cause some like pretty much like your hypertension is going to be like one of your main things that you'll see there. So vasoconstriction. This is a little bit of a different one because there's like an attempt, like you can see that there's like a disconnect here. Your body's essentially trying to do two things at once. And so you have vasoconstriction. That vasoconstriction leads to hypertension. And then here I said the brain attempts to compensate the above by doing what? Yeah, which is a little bit different than what we're used to because usually when we're triggering the sympathetic nervous system, we're causing tachycardia. But in this case, there's that disconnect. They're not functioning, they're not connecting, they're not communicating appropriately. So you kind of have these um, different things all going on at once. Your body's like overreacting to this input, leading to severe vasoconstriction. So you're going to have really bad hypertension. And then there's that disconnect where you're having that like slowing down of the heart rate. Your body's trying to compensate for it. It's not able to stop the hypertension. So it's a very strange condition where you end up having hypertension with slow heart rate. Okay. So what are some potential causes? And there's two in particular that you'll probably see on tests and stuff. Yeah, so full bladder, and I'll extend that to even like a full Foley bag. So a full bladder or even like the Foley bag being full. So if it's full and then there's some pee left in the tube, makes it all the way, it's like all that pee still through the tube and it's causing some sort of stimulus there. The full bowel, yeah. So constipation, these are going to be your two big ones that can lead to this condition. And then other than that, it's just be like any stimulus or pain. But these are the two you'll probably see the most on tests. We already talked about the some of the signs and symptoms. The main two here, so the really high blood pressure. And I kind of wrote here, whenever you have high blood pressure and a headache, 'cause that's another condition, kind of goes with the hypertension, you should also worry about potential stroke or maybe like an increased intracranial pressure, and then bradycardia, which I'll move to be closer so that you can have the trio here. So it's going to be these three are the main ones to think about. Sweating above the injury, yeah, so that's mentioned here. So all of these are potential things. So now what are going to be your interventions? That's going to be your number one thing. So if you get a question where this is occurring, your patient has a full Foley, their Foley catheter bag is full. Patient's blood pressure suddenly like 200 over whatever, um, or like some crazy amount. While their heart rate is slow, what is your first action? It's going to be head of the bed up first. Cool. Anything else that you could do also? hmm So identify the stimuli. So if it's bowel, are they do they have some sort of distension? Are they impacted, meaning like the poop is stuck, causing a sensory input? Is the Foley catheter bag full? Does it need irrigation? Is there retention? Is there a kink in the tubing that's causing a backup of that urine? And then when in doubt, you can call RRT, but the key thing is you want to treat the cause, not just the BP. So treat the cause, not just the BP. Think the emphasis for this one uh, is for you to put the head of the bed up, find the stimuli, call rapid response if needed. But this is an emergency because your body's not making that connection due to the damage to the spinal cord. So it's not able to stop itself from reacting to that stimulus. It's uncontrollably increasing the blood pressure. It's also at the same time trying to compensate by consistently decreasing the heart rate. So it's kind of doing two bad things at once, and two wrongs don't make a right. So uh, that's why, it's a emergency. That's pretty much it, though. How long did we spend? Like 2 hours, a little bit over 2 hours with this one. Any questions on spinal cord injuries? And I don't know if I did this already. Ba-ba-ba. I'll post both. If you guys want the PDF, I've been posting the doc recently, but if you want PDF, I'll do that too. Just let me know. And then tomorrow you guys have your Kaplan, so good luck on that.